Hello, dear colleagues. How are you? My name is Mynzhylky Berdikhojayev. My assistant is Abzal Khairatulu Jumabekov. Operating nurse is Zoya. And we have a special guest from Kyrgyzstan, my student and fellow Rıskelde. Rıskelde is a neurosurgeon from Bishkek, Kyrgyzstan. And he came with the patient, specially assisting the patient. He's a relative, and we are preparing the patient for the following cases. You will see. The case number 1 from National Hospital of the Medical Center of the Presidential Affair of the Republic of Kazakhstan. It's a very specific naming. I think in abroad you just call it the presidential system. Presidential Hospital, Almaty city, which is in Central Asia, near the Tian Shan Mountains. The other side is Himalaya. Himalaya also cover the territory of China, Russia, Uzbekistan, Kyrgyzstan, Tajikistan, Afghanistan, and India. Some part is in Nepal also. And it's a beautiful city. I like to come to Almaty to do live cases. Unfortunately, for this year, the number of cases is limited twice than in 2024, but it's not a problem. We can take a rest, we can go for vacation, we can attend international meetings. So one word, we are happy. But for our patients, it's not so happy situation. We have a quotation for this year, and the number of quotation is 2 times less than it was in 2024. That's why we can treat for free the limited number of our citizens. We are ready to treat, but the economical situation in the world and also in Kazakhstan, it's not so good. That's why, okay, there is the limitations. Stentash Perisal. Гепарин бес мың саласаңыздаршы. Patient is already medicated with the ticagrelor and aspirin. Loading dose of ticagrelor is 180 milligram and the aspirin is 100 milligram daily. And following ticagrelor is 90 milligram twice a day. A young lady, 44 years old, with this paraclinoid intradural aneurysm. And it's incidental and ruptured, but the patient has a headaches. For this region is very specific. Patients has a headaches in supraorbital branch of the trigeminal nerve on the left side. Basement. I know from many patients, if you ask them very carefully, nearly all of them has this territory headaches for many years, and then after the treatment, the headaches are disappearing. Анан көтен жағын дөргітет жүрш, гемодинамика секіріп отыр. Ана жерде провод көтін дөргітет жүресіш. Бергі провод болады обычно, сон сәл қозғасаң қояды. Бергісі, арғысы емес.
Жөндейтін кісілерге
Все. Болды, тоқтады.
жөндей алмай қалды.
Okay, thank you. It's moving. The contacts are not so close. Yes, it's an economical situation. It's even better than in neighboring countries, but yes, it's even better now in Los Angeles. There is a strikes and there is a new politics in US about the migrants, but it shouldn't do us happier because we have our own healthcare problems, and we shouldn't cover all these problems with the problem of the surrounding people and surrounding countries. Yes, that's why. Yes, for politicians, it's a very good situation to say, okay, you see the entire world, there is a problem, and you're living in a very good condition. But, okay. It's a principle of British fire workers. If there is no fire, it's very good condition. Yeah? Okay. Okay. I am planning to visit UK this year twice, and I hope I can see the fire workers in UK this year. Okay, stent is opened. It's properly positioned. This treatment is also, from the economical point of view, the aneurysm is wide neck. At the end of the treatment, the segment is diseased. Patient has has good collaterals. You can see there is a contralateral ecom territory. The second ACA is in place. It's very important, and also patient has a PCOM. On the right side has PCOM. There is some dilatation in cavernous segment. It's dysplastic. Might be it's a beginning of the aneurysm. We will follow this segment on the right side. It's not the topic of this treatment. Okay. There is ACOM, there is a ACA contralateral and ACA first segment. This is the sizes of the aneurysm. This part of the ICA is also abnormal, and if you don't stent this segment, usually on follow-up it could be the problem. Both PCA territory are present, and we have PCOMs on both sides. The circle is closed. It's very good. If any problem with the stent, then PCOM and the ACOM can take the circulation and can save the life of the patient. Exclude the ophthalmic artery territory. The flow diverter placement has a risk factor for the retina, and from some literature it may take 12%, but in 98% of the patients, good extra intracranial collaterals, and even ophthalmic artery may occlude the meningeal branches, and the nasal artery may take the territory and supply the retinal artery. Usually it's not a problem. Placing the stent in this segment and placing for 3-4 millimeter coils, it's a minimum 4 or even 5 coils. It's nearly $4,000. The stent Leo Plus is $4,000. Balloon for the assistance is $1,000, and the wire with the microcatheter another $1,000. In total, it's $9,000-$10,000. and the price of FD is nearly $9,000. And long-term follow-up is reliable. That's why we decided to place flow diverter stent. It's a local anesthesia, and after the treatment, patient will go to the department, will escape the stage of ICU. It's also the positive part. If you place the coil and stent, most of the cases we prefer to do it under general anesthesia. The time of the treatment is shorter, twice nearly. That's why it's better. Maybe better, maybe not, but we are following all these patients with the ophthalmic supraclinoid paraophthalmic cavernous segment aneurysms, and in our experience with the visual problems, I have seen a couple of patients out of 300 or 400 previously stented with the flow diverter stents in our experience. It's less than 1% in our experience, but maybe blind complications, scotomas is present, but it's not symptomatic. Yes, the stent is okay. Now it's 4 minutes after the stent deployment, and there is a nice stagnation. Let's do the control angio in AP and lateral. The stent was 425 by 25 Silk Vista. The delivery catheter was headway 21, and the microwire we took coronary 14, which is Xeon Blue. And I know the comments from the colleagues. The coronary devices is not the best one for the intracranial circulation, but from our experience since 2016, I think, on the regular base, we're using coronary wires for the intracranial stenosis. And nowadays, in proximal aneurysms without complex anatomy, time to time for the headway 21, 27 delivery, it's possible to use for navigation the coronary wires, which is 14, which is shorter, but this one. And with this simple J shape, it's hydrophilic. Chikai Asahi Xeon Blue, and which is hydrophilic, and with this tip, and it's very stable, you see? If you take narrow wires, usually they fall down, and it's not give stability. And for the balloon angioplasty in intracranial stenosis, I prefer to use these wires. It gives support for the balloons. Balloons came from the coronary business, and it's better to use the proper instrument for the proper material, and then you have a good navigability, and the need of intermediate catheter use is less when you use the stable devices with the predictable behavior. Okay, now it's at nearly 7 minutes. On minute number 7, everything is okay. Now I will ask Abzal to do control CT, expert CT. It's a protocol. Because we navigated the intracranial circulation, MCA territory, we should do, even it's extracranial, we can change the hemodynamics, and we may cause any kind of intracranial complication. That's why I prefer to use expert CT to control for documentation. Patient is under local anesthesia, we can communicate with her. У вас все хорошо, бәрі жақсы ма? Аяқтың басын қимылдатыңыз. Аяқтың басын қимылдатыңыз. Қолдарыңыз қимылдап жатыр ма? Everything is okay, patient is okay. Басыңыз ауырды ма? Қатты ауырды ма? Қазір қойып қалды ма? Okay, she experienced some pain at the time of delivery of the stent, but usually it's very temporary. It's from 5 to 20 minutes, and then the pain is decreasing. It's even better than intubation, and after the operation, patients are suffering from the throat pain for 1 week, 10 days, and sometimes it's complicating with the tracheitis, laryngitis, pharyngitis, laryngitis, tracheitis, and under local anesthesia is better. Also, we discussed with colleague from Buffalo. He's from team of Adnan Siddiqui, Levan, I think. I could be incorrect. I will check. Levy, yes. Elat Levy, yes, and he's doing more and more cases under local anesthesia, and we are doing also. You can see on our recorded cases, nearly 70% of our intervention nowadays is local anesthesia. Nearly all ICA aneurysms, V4 segment aneurysms is local. Sometimes MC aneurysms we are doing local without complex anatomy. Meningioma is local, subdural hematoma is local, and the intracranial ICAT cases, almost all under local anesthesia. For the general anesthesia, we left the fistulas, brain AVMs, which need a general anesthesia, and distal aneurysms. Nowadays is general anesthesia. Okay, Abzal now will do expert CT. If expert CT is clear, you can see on the main screen. Abzal will scroll, and on minute 15 now is the 10. If everything is okay, he will show like this, and then we disconnect the video transmission. Next case is spinal dural fistula. We will do spinal angiography under general anesthesia, and then we'll see where is the problem. We will try to exclude the dural fistula. Patient has a myelopathy on the thoracic spine and has several vertebral bodies in thoracic level, compressive fracture on the osteoporotic changes, but he's functionally independent, has some pain. We will see next patient. This patient unruptured, but with some headaches. Okay, see you in 30 minutes. Катастир. Звук можно выключить?